Thank you, Karthik sir, for introduction. In fact, Dr. Karthik Kailash was my teacher at MIOT. He was there for few days. So I am happy that I give this lecture in front of him. Thank you, sir. So today's topic is awake spine surgery. In fact, my exposure to endoscopic spine surgery started in Pune in 2011 by Dr. Gore. So I am extremely grateful for introducing me to this beautiful world of endoscopic spine surgery. Why awake spine surgery? We all started with transfemoral surgery, which is done under local anesthesia and sedation. So the rationale is neuromonitoring. Awake patient is the best neuromonitoring you can have, and it is possible to do surgery in patients who are at high risk. These are the other added advantages. You can do it as a daycare surgery, no ICU, no catheter, no IV fluids. Patient can go home same day. But over the years, the indications for these surgeries have really expanded. We do wide spectrum of pathologies with endoscopic procedures and minimally invasive surgeries. And true minimally invasive surgery has to be least invasive, including anesthesia. There is no point in giving GA with the full intervention and saying I am doing minimally invasive spine surgery. It doesn't make sense. So it is for you to think about it. The awake spine surgery, we do wide spectrum of procedures from endoscopic discectomy, we do endofusions under regional anesthesia, implant removal, percutaneous fixation, vertebroplasty, biopsy, pain interventions, epidural abscess drainage, discitis, injections. And the type of anesthesia, we do it either local and sedation. Spinal anesthesia, it is in between because here the patient is not able to monitor his neurologic status, but it's still awake surgery. And epidural anesthesia, we do analgesic dose. The factor deciding which type of anesthesia you are going to do in particular patient depends on the procedure type, probable duration of your procedure, and patient factors. So the surgeon and anesthetist will take a call what type of anesthesia we are going to do. I do most of my lumbar interventions under spinal anesthesia, especially the interlaminar procedures like discectomy, decompression. We can do vertebroplasty, implant removal, all under spinal anesthesia. Normal spinal anesthesia, you will get a duration of 2 to 4 hours, but you can extend it by using either dexmedetomidine or one of these agents which you can put into the spinal anesthesia. The anesthetist will do it. Advantages, it is simple, quick, predictable action, very cheap, immediate pain relief, awake patient, and ideal for daycare surgery, but it has its own limitations. The duration of action is limited. There can be blood pressure fluctuations, and if you are doing a long procedure, patient can have neck pain and headache, and elderly patients can have urinary retention. Another limitation is you cannot do neuromonitoring. So we do this when you don't require neuromonitoring. Sometimes there can be delayed recovery. It is not advisable with patients with poor cardiac function. If there is failure in anesthesia, then you can repeat a spinal. You can continue with local and sedation because you are not doing a maximally invasive surgery, or you may have to switch to GA. Epidural anesthesia, we do generally use this for transfemoral discectomy, endofusion, or sometimes when you have to do a combined procedure, we do it on epidural. And even interlaminar endoscopy can be done under epidural analgesia. The best part is you can do neuromonitoring. Blood pressure remains stable, but this is controversial. Duration, you can extend it. Patient recovers immediately. Depth of anesthesia can be varied. However, it is time consuming. There is a cost factor compared to spinal. We need a good anesthetist. Sometimes there can be a patchy block or a varied motor block. Local anesthesia, we don't use it nowadays very often, but it is good for cooperative patients undergoing transfemoral surgery. But it is not suitable for patients with severe pain, If you give too much sedation, there is a risk of hypoxia or nerve injury. Sometimes patient becomes uncooperative, and if the patient had pain, it will be an unhappy experience for him from the surgery. This is a patient with a compression fracture of L1 vertebra. We do this under spinal anesthesia. Another patient, 65-year-old patient. Some cases I am going to show how we do it under regional anesthesia. This is an endoscopic fusion. This you can see very severe canal stenosis. So this was done. We did an endofusion first. Sorry, can you play the video? Yeah, it's here. Okay. So this is how beautifully you can prepare the end space, end plates. You can never see this with any of the open surgeries or other forms of surgery because your scope goes right into the disc space. And that is the cage and that is the exiting route which is decompressed very well. So this is a post-operative X-ray. Patient had endofusion plus interlaminar decompression. This is the scars. You can hardly make out the scars. These are transverse wound which don't even require skin sutures. So another case, 60-year-old patient with myeloradiculopathy due to L1, L2 discitis. So we have to do a debridement and biopsy. One, to identify the type of pathology, and second is to decompress the cord. So this was done endoscopic, it turned out to be tubercular and it healed very well. This is another case, patient with epidural abscess, massive epidural abscess. You can see it here. Patient had cauda syndrome with bilateral lower limb paralysis. You can see the massive abscess. This was done with endoscopic, transforaminal endoscopy. You can see the pediatric Ryle's tube going in there. This is a short video. Can you play the video? So this was done transforaminal. We used pediatric Ryle's tube here, which was passed under the dura, extended proximally. You can see the pus coming out through the abscess, through the Ryle's tube. You can see the pus being drained, and the Ryle's tube is left as a drain. This was published in JMISST, and this is a post-operative MRI scan. Patient made complete recovery and with a 7mm incision. This is the beauty of AVIC surgery. This is another case, 50-year-old patient with fracture dislocation. This I did recently. It's more of a translation injury. Again, it was done endoscopic stabilization and fusion. With interbody fusion, we put a lot of bone graft, so it should be fine. Complications, you leave it to anesthetist, but you should know atropine and mefetrepine, two drugs which can be life-saving. Take-home message, we can use any type of anesthesia depending on the various factors we have discussed, but most important factor is even local anesthesia is associated with risk. You never know when the disasters can strike. So always you can avoid trouble if you take a proper consent, documentation, communication, and sympathy, humbleness, and generosity towards the patient. These will avoid you trouble, even in case of a disaster. And you should have a good anesthetic team. Thank you.